Okay, so today we're going to talk about two of the electrolytes, sodium and potassium. And the reason that sodium and potassium are really important, and we'll learn this as we go along, is that it is essential for our neurologic and our cardiac function. So when we look at sodium, it is the main cation of the extracellular fluid, or also known as the ECF. It is the main determinant of the osmolality. So we know that with osmolality, if there's too many solutes and not enough solvent, we're going to have a dehydrated person. If we have too much solvent and not enough solute, we're going to have an overhydrated patient. So sodium is the one that determines the osmolality of our patient. We know that with sodium, the intake is mainly through the GI tract, and if we look at our diet, what do we get sodium from? We get it from salt on our French fries. We get it from our meats. We get it from our vegetables. We get it from a lot of different places. It is also eliminated in the urine, and this is where the kidneys come into play. The kidneys, if there's not enough circulating volume, they will initiate the renal angiotensin system, which also will stimulate aldosterone, which causes us to save sodium and to save water when if that's with aldosterone. With the renal angiotensin system, that's based on our blood pressure. If this is a problem for you guys, then you're going to need to look at your anatomy and physiology again. So when we look at hypernatremia, this is a sodium greater than 145 milliequivalents per liter. It can be caused by insensible water loss. So for our patients that have a fever, it can be from hyperosmolar tube feedings. We know that we know that our body automatically tries to dilute something that is hyperosmolar, that has too many solutes and not enough solvent. We can see this with heat stroke. We can also see it for patients that have a sodium gain. So for patients that have IV fluids that have a lot of sodium in it, we can see it with excessive aldosterone. What happens is our patient, we have the elevated sodium. This causes a hyperosmolarity. That means that we need more water. It's going to shift the water out of the cell and into the intracellular space. This is going to lead to cellular dehydration. All of our little cells are going to be all wrinkly and crinkly. Our clinical manifestations, we're going to see, especially if it's due to a water loss, we're going to see an intense thirst. We're going to see a thick, dry, swollen tongue. The thing with sodium, we're going to see restlessness and agitation. If it's because of a water loss, our patient is going to be hypernatremic. So we're going to see a weight loss. We're going to see hypotension and weakness. Eventually, if it's severe because of this confusion and weakness and it works on the action potential, we're going to see seizure, coma, death. Now, if it's because of a sodium gain, we've given our patient way too much sodium chloride in their IV, we're going to see a weight gain because we've got extra water. They're going to see edema because of extra water. We're going to see a hypertension, again, because of the extra water. We're giving them sodium. We know where salt goes, water follows, and we're going to see a weight gain. And in severe cases, again, seizure, coma, death. With hyponatremia, this is going to be caused by a water gain or sodium loss. So it's going to be kind of the opposite. It's going to cause a hypoosmolality, meaning we have more water and less solvent or less solutes in our blood. So our sodium is going to be less than 135 milliequivalents per liter. This is going to cause all of our little cells to swell. So some causes of hyponatremia can be a water gain. So we see this with some of our disease processes. We'll talk about syndrome of inappropriate antidiuretic hormone. We see this with congestive heart failure because the heart can't pump up well enough that we get a backlog of water and we have a hyponatremia. It's a dilution thing. We can have it with surgery or trauma. We can also see a sodium loss with diarrhea, vomiting. NG suctioning can cause a sodium loss. We see this with diuretics. We're going to see a hyponatremia. We're going to see it with those fasting diets. We're going to see a hyponatremia. What we're going to see with our patients, clinical manifestations, even if it's water gain or sodium loss, we're going to see headache, weakness, confusion. The confusion is due to the swelling of the cells, the swelling in the cells in the brain, irritability, apprehension. We're going to see a weight gain due to excess water, if it's a water gain, and we're going to see some hypotension with a sodium loss. In all cases, we're going to see tachycardia and dry mucous membranes. They're going to have muscle spasms. We're going to see hypertension. And again, seizure, coma, death. So now we've kind of talked about sodium. And when I think about it, I think sodium, brain. Sodium, my brain, my confusion, sodium, seizures. When it comes to potassium, potassium is the main cation of the intracellular fluid. So we're going to see more potassium in the cell than we're going to see potassium outside of the cell. It's the main determinant of the resting neuron potential. Balance is essential for skeletal, cardiac, and smooth muscle contractions. Intake is through the GI tract. We have those potassium-rich foods, fruit, dried fruits, vegetables. Also have to watch salt substitutes. We tell our patients don't take a lot of salt in, so they go to the store and they see salt substitutes. Salt substitutes have potassium chloride in it instead of sodium chloride. So they can actually have a hyperkalemia because of the salt substitutes. We can see insulin can cause extracellular potassium to move intracellular. And this becomes important for when we look at a collaboration with our physicians on if our patients come in with hyperkalemia. When we look at, we're going to look at first, wrong way, sorry. Hyperkalemia. Oops, okay, sorry. Hyperkalemia. This is the most common cause is renal impairment. We know that the kidneys regulate the sodium and it also regulates potassium. We can also see hyperkalemia with trauma, with cell tissue destruction. We see it with burns or crush injuries. We'll see a hyperkalemia. Again, those potassium-rich foods and those salt substitutes. Some of the causes: excess potassium intake, excessive or rapid IV administration. One of the things we do to treat our patients with hypokalemia is to give them IV potassium. Now, of course, we're not going to give it IV push because that will kill them. But we can give them too much IV solution containing potassium and actually turn them into hyperkalemics. We can see it with potassium-containing medications. We'll see it with acidosis. We'll see it with renal impairment. So some of our clinical manifestations: irritability, anxiety. Again, it works for our skeletal muscle. It works on our resting neuron potential. Abdominal pain, cramping, Diarrhea, we'll see that. Weakness, especially of our extremities. Irregular pulse. And we're going to see EKG changes. And I don't want you guys to get really excited about EKG changes. We'll see more of that when we get to cardiac. In severe cases of hyperkalemia, a potassium greater than 7, we can actually have a cardiac death. With hypokalemia, this is our potassium less than 3.5. Most commonly, it's due to losses. We can see this with GI, so nausea, vomiting, diarrhea. We can see it with diuretics. A lot of our diuretics, our loop diuretics, are famous for this, where they actually dump the potassium, the calcium, the sodium, and the magnesium. With these, we can also see it with those starvations or our low potassium diets. So our clinical manifestations, we're going to have fatigue, and we're talking an overwhelming, oh my gosh, I can't lift my head from the pillow, fatigue. We may see leg cramps with this. Patients complain of severe leg cramps when they have hypokalemia. We're going to see soft flabby muscles. We're going to see a decrease in our reflexes. We're going to have a weak, irregular pulse. We're going to see polyuria, and we're going to see EKG changes again. And like I said before, we don't want to get excited about EKG changes. Don't worry about it. We'll talk more about that when we get to cardiac. So that's kind of the overview on potassium and sodium. And I hope you enjoyed it and come to class with your questions because we'll have some excitement there.